First, I'll talk a little bit about thyroid and parathyroid disease. Now, I understand you're going to have some talk about this, I think, later in the week, but I will go over this detail as well. We'll talk about salivary glands, the oral cavity, the neck, and, of course, congenital abnormalities that you need to know about. The thyroid anatomy we'll talk about first, and then we'll go into some of the thyroid disorders, many of which are not surgical disorders, but we'll need to know them anyway because some are consequences of what we do to patients, so we know how to recognize them and treat them. We'll talk about benign tumors and malignant tumors of the thyroid as well. The thyroid begins as an endodermal bud from the floor of the pharynx between the first and second branchial pouches. Now, this is important because one of the disease states that you'll need to recognize, at least in the pediatric or teenage population, is a thyroid glossal duct cyst, which begins, at least tracks from the foramen cecum. And part of that operation involves tracking all the way back up to the base of the tongue to remove the entire tract altogether. The dual arterial blood supply is important to know. The subclavian system and the external carotid artery. The subclavian supplies the thyrocervical trunk, which gives off the inferior thyroid artery, and the external carotid supplies its first branch, the superior thyroid artery. There are three pairs of veins, the superior, middle, and inferior. The middle veins, of course, most of us start off by dividing when we mobilize the thyroid, so those are important to know. And the thyroid is innervated through the autonomic nervous system. Going into some of the thyroid disorders, we'll first talk about hypothyroidism. Hypothyroidism is not a surgical problem, but it can result from what we do. Most commonly, it's a result of something spontaneous, usually a result of autoimmune thyroiditis. Autoimmune thyroiditis typically occurs in middle-aged women in which a goiter is either missed or didn't develop. Or it could be iatrogenic in nature, obviously as a result of thyroidectomy, or iodine ablation for treatment of Graves' disease, which is very common. 10 to 30% of the time after surgery for Graves' disease, patients become hypothyroid. We can also induce hypothyroidism by using or administering drugs. Such drugs as iodides, sulfazoxazole, as well as lithium can produce a hypothyroid state. There's a wide spectrum of manifestations that can present in the hypothyroid patient, either from someone as asymptomatic with just a mild elevation in their TSH to myxedema coma. The treatment for hypothyroidism is hormone replacement. Thyroiditis can be classified into acute and chronic. Acute thyroiditis, although rare, especially acute suppurative thyroiditis, is very rare, and is secondary to bacterial involvement, usually strep or staph or pneumococcus. Traditionally, it's treated by antibiotics, but may require surgical intervention for either needle aspiration for diagnosis, or an open drainage procedure, or even sometimes a partial lobectomy if this involves a thyroid abscess to remove the abscess completely. Subacute thyroiditis is usually a viral event. It comes on slowly, can sometimes present with a mildly enlarged or inflamed gland, low-grade fevers and some pain, usually viral, as I mentioned, and is somewhat self-limiting and can be treated at least with aspirin. Sometimes corticosteroids are needed, but is rarely a surgical problem. Moving into the chronic category for thyroiditis, the two that you probably need to know, Riedl's chronic thyroiditis is a chronic inflammatory disorder that remains idiopathic. We don't really know why this happens, but the thyroid becomes extensively fibrotic and stiff, and can become very large and can frequently impinge on the airway and cause significant neck discomfort. So sometimes there is a surgical indication for debulking of the gland, but does not treat the actual condition. Hashimoto's is a very important entity to know. It is the most common presentation for thyroiditis. It is due to a lymphocytic infiltrate. It often is painless, and it presents because of anti-thyroid antibodies, much the same way in which Graves' disease occurs, but in terms of Hashimoto's, it's more in terms of producing a hypothyroid state when the thyroid burns out. Hashimoto's is also very commonly related to autoimmune processes elsewhere in the body, such as autoimmune gastritis and pernicious anemia, Schmidt's syndrome, which is a combination of Hashimoto's and adrenocortical insufficiency, and it's named Schmidt's syndrome. Diabetes, myasthenia, Sjogren's syndrome, rheumatoid arthritis, lupus, and any other of the rheumatologic inflammatory states can be associated with Hashimoto's disease. Let's move on to hyperthyroidism. Hyperthyroidism most commonly is either due to Graves' disease or a toxic multinodular goiter in 99% of cases. Graves' disease is the most common cause. Graves is an autoimmune process that is similar to Hashimoto's in that there are anti-thyroid antibodies that actually stimulate the thyroid to overproduce. The treatment can be medical, surgical, or ablative in nature, and there are risks and benefits of doing all of the such, but we may frequently be asked to remove someone's thyroid or part of the thyroid for Graves' disease. What's important to know about the hyperthyroid state when asked to do this is the pre-op suppression of the thyroid before undergoing surgery. It's important to suppress the patient for 3 to 4 weeks before attempting to remove the thyroid in a Graves' patient to prevent a hyperthyroid crisis. Frequently, we can do this with drugs such as PTU or Tapazole are the two most common drugs, which shut down production of T3, T4. We frequently will also give iodine replacement. There's a solution called Lugol's solution, which is a combination of iodine and potassium iodide, which can be given for up to 10 days prior to the operation, is usually stopped at the time of operation. Now, what's important to know about iodine replacement in this case is that iodine itself, when replacing it, can actually suppress T3 and T4 production. But it's kind of a mixed blessing because if you continue the therapy, you may also stimulate production later on. So you need to know about that. We also can slow down the symptoms of hyperthyroidism by using beta blockade. So Inderal is a frequent drug you would use perioperatively to slow the heart rate. You surely do not want to operate on someone who goes in with a tachycardia, so you probably want to aim at bringing their heart rate down into the 80s before taking them to the operating room. Graves' disease is characterized by an enlarged thyroid glands. The other things that you may remember is exophthalmos, the tachycardia, and the tremor as a baseline. The other more common problem that can cause hyperthyroidism that we will frequently be involved in is toxic multinodular goiter or a toxic solitary nodule. The woman in the picture down here in the corner has a toxic multinodular goiter, which presents with multiple nodules with autonomous function. The treatment is aimed at either subtotal thyroidectomy or debulking, usually to leave some remnant of thyroid tissue behind, but really to not remove all thyroid tissue to put them at risk for hypoparathyroidism or nerve injury. The toxic solitary nodule most commonly is due to an adenoma, and the treatment aim there is to do a unilateral total or subtotal lobectomy for removal of that nodule, which is successful in over 90% of cases. Moving on to benign neoplasia from the adenoma, let's talk briefly about the adenoma. It's the most common cause of benign neoplasia, and they're nearly all follicular in nature. It usually presents as a thyroid nodule, and the initial diagnostic tool would be the FNA, the fine needle aspiration. On FNA, you may find a result that is classified into either benign, malignant, suspicious, or non-diagnostic. 70% of the time you'll get a benign finding, 5% of the time a malignant finding. 10% of the time you'll get a suspicious reading, and about 15% of the time you'll get something that says that this is non-diagnostic and we need to get further specimens. Unfortunately, for the benign adenoma, we need to exclude follicular carcinoma because on FNA this can look very similar. So the diagnosis of a benign adenoma cannot be made by FNA. We may start off by doing an FNA, but you cannot make the definitive diagnosis of a follicular adenoma by this test alone. This is very important, and this will present on the board exam, and you'll be asked this on your oral boards as well in many scenarios. You need to take this patient to the operating room and do a lobectomy. And have a completion and wait for the actual final path to come back. Frozen section is not very helpful either. The mainstay of diagnosis of the carcinoma would be to see capsular invasion or vascular invasion on the final pathology, which again is not something you typically see on frozen section. So we must inform our patients that they may need a completion thyroidectomy if this were to come back as cancer. But you will cure them of their adenoma by doing a lobectomy. If this is a toxic adenoma, just to add one more statement here, the preparation would be similar to that of a patient with Graves' disease. However, the iodine replacement in this case probably would not be necessary because of the focal involvement of the adenoma and not the diffuse glandular involvement as the case with Graves' disease. Moving on to malignant neoplasia of the thyroid. 1.5% of cancers in the United States are malignant thyroid cancers. Over 95% of endocrine malignancies are in the thyroid gland. The majority present with a palpable nodule, although less than 10% of these nodules will be malignant in nature. The risks for thyroid carcinoma would be a family history, which is one of the most important, and neck irradiation in their past history. The younger the patient and the older the patient. It's a bimodal process, the more likely the risk of cancer, especially over age 60, the more likely to be a carcinoma. Papillary carcinoma is the most common malignant tumor that represents about 3/4 of the tumors you will identify in the thyroid. There is a female predilection, 2 to 1. Psammoma bodies may clue you in on the board exam that they're talking about papillary carcinoma. And if you remember the PPP rule, which is papillary carcinoma, psammoma bodies, popular, and there's one more, I think there's like a 4th P in there, but at least those 3 will guide you towards papillary carcinoma. It is a slow-growing cancer. It metastasizes via the lymphatics, and it's frequently multifocal and multicentric, which can change the nature of what you do for these patients. The typical board answer for papillary carcinoma is a total thyroidectomy. This offers you a couple of advantages. One is it reduces local recurrence. Number 2, it manages the multicentricity and multifocality of the tumor to prevent local recurrence. And number 3, it also helps you monitor these patients because you can follow serum thyroglobulin levels after the resection to track recurrent disease. And you can also treat any recurrence with radioactive iodine ablation since there's no residual thyroid tissue. One may also argue, however, that if the tumor is less than 1 centimeter and there's no evidence of metastasis, you can perform a unilateral lobectomy and isthmusectomy and follow the patient very closely, either by serial neck exams and ultrasounds, and this would be considered adequate as well, but you would need to state your reasons on the boards and the oral boards for doing such, but I think both are reasonable. Moving on to follicular carcinoma. The second most common malignant tumor, about 1/4 of our tumors will be follicular. This again is slow growing, a female predilection. It spreads by vascular invasion, as I had mentioned before. It peaks in the 5th and 6th decades. And the operation here initially, because most of the time we're ruling out follicular adenoma, would be a unilateral lobectomy and isthmusectomy. And we would move on to perform a completion thyroidectomy if the permanent section was positive for invasive cancer. Medullary cancer, not a very friendly one, very aggressive. It originates in the parafollicular cells. It's a neuroendocrine cell, or the C cells of the thyroid. There are sporadic forms and familial forms. About 75% of medullary cancers are sporadic, and about 1/4 of them are familial. The familial forms may present as the MEN syndrome, which you need to know about. MEN2A and 2B involve medullary thyroid cancer. Pheochromocytoma also goes along with it, and parathyroid hyperplasia for A at least, and then the neuromas and the paragangliomas and the other identifiers of MEN2B. The FNA is used initially for diagnosis and can be very accurate for diagnosis because we can do calcitonin staining of the aspirate, which will indicate a medullary carcinoma. But before operating on these patients, very important to identify calcitonin levels, screen for a pheochromocytoma, because clearly that's the tumor of choice to operate on before you operate on the thyroid. When someone has MEN syndrome, pheo is the most dangerous of them, so you need to identify it and treat that first, and that frequently comes up. You want to check for serum calcium levels and your PTH level, and your operation is going to be a total thyroidectomy, and because of the aggressive nature, you're also going to perform a central node dissection at the time of your thyroidectomy because of its aggressive nature. The worst of all scenarios here, your anaplastic or undifferentiated carcinoma, it represents about 5% of our cancers in the thyroid. They are usually symptomatic because of their high rate of growth and their invasion of the surrounding structures. Frequently, patients will present with severe pain in the neck. They may present with hoarseness and focal cord involvement. And these are rapidly progressive and obviously very poor prognosis associated with them. An operation here is not going to cure these patients, and for the most part, our care in this group would be for debulking, and complete excision rarely removes the tumor. And it's mainly for airway protection that we're operating on these people, and frequently they'll end up trached if you're concerned about compression. Lymphoma, very rare, less than 1% of thyroid malignancies, usually non-Hodgkin's, but something also important to know is that it's very commonly associated with Hashimoto's disease, very commonly. It's a rapidly enlarging painless mass that they may present with, and the treatment, remember here, is not thyroidectomy. It's diagnosis, FNA diagnosis, and chemoradiation. Radiation and doxorubicin-based chemo are the standard, and surgery is rarely indicated for lymphoma of the thyroid gland. Moving on to parathyroids. The anatomy, not so difficult. Usually 4, can be up to 8, 6, but the goal, obviously, to identify 4 in most of our explorations. The superior glands are more constant in position, and that's probably because they're derived from the 4th pharyngeal pouch, and we say that the inferior glands are more variable because of the longer course that they have to travel from the 3rd pharyngeal pouch, and you just remember that they're flipped. The upper glands come from the lower pouch, and the lower glands come from the upper pouch. In terms of disorders, hyperparathyroidism is a common disorder that we will frequently get involved in as surgeons. Primarily, it's due to an adenoma, which is 80 to 90% of cases. About 10 to 15% is primary hyperparathyroidism due to hyperplasia or foregland hyperplasia, and rarely due to carcinoma. The presentation, as you'll remember, we used to say this on rounds, the stones, bones, groans, and psychiatric overtones. That will help you remember these patients who are hypercalcemic. You'll obviously diagnose them by their serum calcium levels and their PTH level. So who do we operate on? Well, we operate on all symptomatic patients. We operate on those with serum calcium elevation greater than 1 milligram per deciliter over the normal serum calcium. You can monitor their 24-hour calcium excretion, not really done, more commonly done in the renal population. Those that have renal failure are looking for secondary and tertiary hyperparathyroidism. Young patients will frequently operate on more commonly, under 50. And the patients that have significant renal involvement, those that have a drop-off in their creatinine clearance, for those who are age-matched, will operate on, as well as those that have bone loss. So bone density is another indication for an operation for hyperparathyroidism. You're going to do a parathyroidectomy, and how you're going to do this traditionally is a 4-gland parathyroid, or at least a 3.5-gland parathyroidectomy for the hyperplasia patients, and hopefully you'll have an adenoma they'll be able to plop out of there, which would be 90% of the time. Traditionally, you'll do a complete exploration of the neck. This is a 4-quadrant exploration looking at all glands. More commonly now, there are new approaches to this, and our head and neck surgeons may decide to do a directed parathyroidectomy using either video assist sometimes. They'll frequently get a preoperative sestamibi scan to help localize the parathyroid adenoma, and may also use intraoperative PTH monitoring, which gives you real-time assessment of the drop in PTH after removal of the parathyroid that's causing the hypersecretory syndrome. The diagnosis made if you're doing this is usually a 50% drop-off after the first few minutes. The majority of the time it takes at least 10 or 15 minutes to get this back while you're in the operating room, but is a very useful way to minimize your four-gland approach. But the conservative board answer here, if you're taking your orals, is to look at all four glands and take out 3.5 if all four are suspicious. You're going to biopsy probably at least 2, showing 1 normal, 1 abnormal. You can probably stop your dissection there if you have at least 1 normal, if you identify at least the others. And you're going to reimplant your half glands either into your sternocleidomastoid, into the region that you're operating, or frequently into the forearm, which gives you an ability to go back if needed and stay away from the neck if the gland would become hyperplastic once again. Once again, going into the adenoma, looking at the benign disease of the parathyroid gland, it accounts for 85 to 90% of cases, and sestamibi scanning is 85% sensitive, and the treatment is parathyroidectomy. Cancer of the thyroid parathyroid is very rare. Macroscopically, it's grayish-white, has a very hard consistency. There's a local reaction around the cancer. There's evidence of local invasiveness, and the treatment's going to be an en bloc resection and neck dissection. Here is not necessarily recommended. Let's move on to salivary glands. The parotid gland has 2 lobes, the superficial and deep lobes. The facial nerve is the important structure here when talking about the parotid. You need to know where it enters the gland, how to identify it, what it innervates, and how to protect it. It enters the gland on the posterior medial aspect of the deep lobe. It exits the styloid-mastoid foramen, and it can be identified between the external acoustic meatus and the mastoid process. It is usually anterior to the attachment of the digastric muscle as it attaches to the mastoid process. And you need to identify this and protect it during a superficial parotidectomy. The innervation of the gland is by the 9th cranial nerve, and this is important because of something you may see or hear about called Fry's syndrome, which frequently pops into the board exam, which is gustatory sweating. And this is a result of post-surgical change. As the nerves are divided during resection, they regrow, and when they regrow, they tend to innervate the apocrine sweat glands in the face. And as we stimulate the 9th nerve during eating, it stimulates those sweat glands to produce sweat, and you sweat during eating, and this is called Fry's syndrome. And that's a very common recognized process. The arterial supply of the gland is via the external carotid system through the superficial temporal artery and maxillary arteries. The submandibular glands, the submandibular gland is located in the submandibular triangle, has a single duct, the Wharton's duct, that emerges from the deep lobe, and it enters the floor of the mouth near the frenulum of the tongue. The sublingual gland lies superficially in the floor of the mouth. It has a multiple series of ducts that either enter into the floor directly or into the submandibular duct, but there is no single duct for the sublingual gland. Talking about infections, which can sometimes be surgical, but rarely. Mumps, something we don't see very commonly due to the immunization process, is a viral infection involving the parotids. Acute non-obstructive suppurative sialadenitis is usually due to bacteria, strep, staph, and H. flu. Dry mouth and dehydration will contribute to this, and you'll see this on your patients sometimes after general surgery. After being NPO for a period of time, they get diffuse glandular swelling bilaterally, and you need to put those patients on antibiotics and hydration, and frequently you can give them lemon drops and things to stimulate production of their salivary gland. Rarely drainage is necessary of a parotid abscess, but sometimes may be indicated. Granulomatous infections are important to know about. TB, actinomycosis, and cat scratch disease will cause a granulomatous infection of your parotid. Then there's obstructive inflammatory diseases, Kussmaul's disease, which is due to fibromucinous plugs in the dehydrated patients. And the treatment here is ductal massage and rehydration. There's also stones, sialolithiasis, which 90% of which occurs in the submandibular gland and very rarely in the parotid due to the size of the duct, most likely. It may result in a secondary bacterial infection diagnosed by palpation or radiographic examination of the duct. You can actually feel the stone lodged in the duct, or you can actually see it on an X-ray. The treatment, again, is gentle massage. Sometimes you can dilate the papilla to help extrude the stone, and you may want to put your patients on antibiotics for secondary infections. Going into the neoplasms of the salivary glands, 85% of the neoplasms occur in the parotid gland. 80% of the time, those neoplasms are benign. 50% of the submandibular tumors are benign, so more commonly malignant in the submandibular group, and even more so, more common to be malignant in the sublingual gland, although rare. The most common benign adenoma you need to know about, remember this one, pleomorphic adenoma. It comes up all over. It's the most common epithelial tumor. It's most commonly found in the tail of the glands. It's slow growing, it's firm, and mobile. The treatment is aimed at removing all involved tissue, not necessarily to remove the entire parotid glands. A superficial parotidectomy or a total parotidectomy will preserve the facial nerve, would be adequate treatment. And just remember, you need a zone of normal tissue around the parotid tumor when resecting this. A recurrence of the pleomorphic adenoma is a surgical failure and was basically due to inadequate margin of resection. This is an example on CT as well as a picture of a woman with a pleomorphic adenoma. They can get very large, very angry looking, but yet benign. The adenolymphoma, or Warthin's tumor, also comes up frequently. It's the second most common benign tumor of the salivary gland. Remember, it is a benign tumor and is treated the same way that a pleomorphic adenoma would be treated. It's almost exclusively in the tail of the parotid. There is a very high predilection for males over females, and usually over 40 years. What's interesting about the Warthin's tumor, it does light up on a TEC-99 scan, so this will help you in your diagnosis. The cause is thought to be due to an embryologic abnormality that as the gland becomes encapsulated at birth, there seems to be an incorporation of lymphatic tissue underneath this capsule, and which would give rise to the lymphoma aspect of the tumor, causing it to be an adenolymphoma. The other benign salivary glands, the oncocytoma, myoepithelioma, hemangioma, important to know in the kids, 50% of salivary gland lesions in children. It appears in the first 6 months of life and usually involutes 2 years later. Why is that important? So you don't operate on them right away. So you should wait at least 2 to 3 years before operating on a hemangioma in a child. Malignant tumors. The mucoepidermoid is the most common malignancy in the parotid glands and the most common malignancy looking at all salivary glands together. It's 70 to 80% of malignancies in the salivary glands, most commonly in the parotid. It can be either low-grade or high-grade in nature. The greater the epidermoid component of the lesion, the higher the grade, and the more aggressive. 44% of patients with high-grade mucoepidermoid cancers have positive nodes on presentation. Here, an FNA, again, will be our initial procedure of choice for most head and neck tumors, and that's something you should remember. But an FNA, like the adenoma that we talked about in the thyroid gland, will not distinguish benign from malignant in this case either. The treatment should be aimed at a low-grade versus high-grade treatment option. A low-grade tumor will be, the treatment will be superficial or total paroidectomy with a cuff of normal tissue sparing the facial nerve and post-op RT. High grade would be a total paroidectomy with a regional resection of the digastric nodes, and you would resect the nerve, the facial nerve here, for a high-grade lesion if it is involved. And of course, post-operative RT would be the mainstay. The actinic cell carcinoma is the second most common, 15 to 20% of malignant salivary gland tumors. 13% will present with regional lymph node metastases, much fewer than the mucoepidermoid. Again, this is a low and high-grade histologic potential. However, the majority of mucoepidermoids and actinic cell cancers tend to be low-grade tumors, and that's something to remember, and in contrast to what happens in the submandibular glands. There is potential for multicentricity. And because of the low rates of lymph node metastases, the routine neck dissection is no longer recommended. And the treatment here is a total paroidectomy. I do want to mention a third cancer that I did not put on a slide that is the most common cancer in the submandibular glands, and that is the adenoid cystic carcinoma. It is not as common in the parotid as it is in the submandibular glands, but this tends to be a more aggressive tumor and is classified as a high-grade tumor. It tends to have a worse prognosis, and it has a high incidence of local recurrence and distant metastasis. So a way to remember this, as though most of the tumors in the parotid are benign, about a 50-50 split are benign in the submandibular. So remember that the submandibular tumor tends to be more malignant and more aggressive, and the most common would be the adenoid cystic cancer. So prognosis for malignant salivary gland tumors would obviously be based on the location. As we just mentioned, the histopathology, the low versus high grade is very important. Involvement of the facial nerve or pain, which would obviously signify a more aggressive tumor. The benign tumors do not invade nerve tissue and do not generally cause pain. It's the malignant tumors that invade local structures, especially nerves and bone and such. Obviously, stage and recurrence. Now, just a brief mention upon staging. I don't want to go over the T&M staging here. I don't think you need to memorize it, but you should remember that the T staging here, at least, is a 2-4-6 type of staging. So T1 lesions are 0 to 2, T lesions are 2 to 4 centimeters, T3 lesions are 4 to 6 centimeters, and T4 lesions are greater than 6 centimeters. And when considering treatment options, low-grade tumors that fall into the T1, T2 category are generally superficial or total paroidectomy that spare the nerve without post-op radiation. High-grade lesions with T1, T2 tumor staging, you're going to treat with total paroidectomy, a neck dissection if they have positive nodes, and you're going to give them post-op radiation to their neck. T3 lesions you're going to treat with radical resections. These are the lesions that are between 4 and 6 centimeters, or any of these tumors that are invading local structures. These are going to be the ones you're going to do radical resections with post-op radiation. Let's move on to the oral cavity. Benign lesions. These are mostly cysts, epidermoid and dermoid cysts, and all the omas. The eosinophilic granuloma, the fibroma, hemangioma, acanthoma, leiomyoma, all the omas. They all present a little differently. The bottom line is they're all treated with conservative excision without need for radiation. And lingual thyroid is on there as well. Let's move on to the more malignant cancers which come up on your exams. The malignant risk factors: tobacco in any form, alcohol. Those that drink alcohol have a six-fold incidence in those who drink than those who don't drink, and UV irradiation, UV light. Premalignant lesions that you need to know about, leukoplakia and erythroplakia. Leukoplakia is a chronic irritation of the mucous membranes that usually has a whitish appearance and is due to epithelial hyperplasia. And this is the usual hyperplasia cancer cycle. Starts as, adenoma due to hyperplasia, then cancer. Erythroplakia has a much greater potential for malignancy than leukoplakia. The majority of these are going to be squamous cell cancers due to where they're located, classified by their pattern of growth, either exophytic, ulcerative, or infiltrative. The exophytic is the least common. It grows superficially and spreads later than the other lesions because it's a very superficial cancer. The ulcerative is the most common form. It rapidly invades and is a very high grade. And infiltrative as well because of its name. It extends deeply into tissues and spreads quickly as well. Squamous cell cancers are staged by the TNM system, and I listed that here. Your main assessment is going to be on tumor size and your lymph node status. That's going to determine treatment. Stage 1 tumors have an equal success of treatment with either radiotherapy or surgery. And these are best treated if they're less than 2 centimeters with surgical excision, and depending on where they're located and whether they're approachable. However, those greater than 2 centimeters may be best treated with radiotherapy. And I think the important thing to remember about radiotherapy for squamous cell cancer of the oropharynx or the oral cavity is that most of the squamous cell cancers are radiosensitive. Bone or deep muscle invasion decreases the radiocurability. So bone involvement or deep tissue invasion are going to be better treated by surgery than radiation. And obvious cervical metastatic disease is also best managed by neck dissection and removal than radiation alone without surgery. So going back to my slide here, surgery is preferred for mandibular involvement. That is true because the bone is going to be less sensitive to treatment from radiotherapy. Clinically positive nodes require a neck dissection. And for the majority of cases that are stage 3 and 4, there's going to be a combination of therapy that's going to involve surgical resection followed by postoperative irradiation. Moving on to cancer of the lip. The most frequent cancer of the lip more frequently involves the lower lip, obviously due to the sun involvement. Involves mostly elderly men. More than a third have outdoor occupations that present with cancer of the lip. UV light is the major risk factor for development of cancer. Most are exophytic and ulcerative. And cervical mets are rare. And as we talked about before, the exophytic type of cancer spreads very superficially and therefore doesn't invade, and so the risk of metastasis is less. So treatment here is either with surgery or radiation, very radiosensitive. Small tumors can be excised with a 0.5 centimeter margin. Clinically positive METs, although rare, may be managed by a neck dissection, and those that have positive nodes should receive post-op radiation. Elective neck dissection for lip cancer is not warranted unless they have clinically positive nodes. Let's go on to the solitary neck mass. This is, we're kind of getting close to wrapping it up here. These next two scenarios I'm going to go through, solitary neck mass and cervical lymph node, enlarged cervical lymph node, are very common scenarios that you're going to get presented with on oral boards if you're about to take those, but frequently come up on the board exam. And so you need to understand how to approach the patient with the solitary neck mass, what the differential is, because they're going to want to know what you're thinking, and how to treat each accordingly. So those that present with a solitary neck mass, you need to think it's either going to be congenital or acquired. Congenital things you'll think of are the branchial cleft cyst, the thyroglossal duct cyst, which we talked already about briefly, and the epidermoid and dermoid cysts and teratomas that can come up in the pediatric population. Acquired diseases are going to be inflammatory, benign, malignant disease, metastatic disease, and trauma you need to think about. So the complete history, obvious, a thorough inspection of the head and neck. And with head and neck lesions, you always want to think about a kind of a bimanual palpation in the mouth, on the floor of the neck, floor of the mouth. You want to do all your direct and indirect laryngoscopy to look at the airway. You may even choose to do a bronchoscopy or even a esophagoscopy to take a look for evidence of other squamous cell cancers. You were going to get your recommended blood work. You're going to do your radiologic evaluation, CT, MR, or ultrasound. And FNA is the most important factor here because they're going to tell you you have a neck mass, and you're going to stick a needle in it, and don't forget that. That's really where you're going to get your diagnosis. It has a 90% diagnostic accuracy. And remember that it is not an incisional biopsy that you're going to perform first. It's your FNA. Incisional biopsy is really not the indicated procedure here. Moving on to the enlarged cervical lymph node, can present as your solitary neck mass. Usually, you can think of it as a benign process, a lymphoma, or neoplastic process. So you need to think about inflammatory conditions and granulomatous conditions for your benign. You'll do your H&P, your ENT exam, same thing as we just talked about for your solitary neck mass. But now you got to consider other things. So you do your FNA, and it comes back with squamous cell cancer. Now that puts you back into the group of cancers we were just talking about. You have your flexible endoscopies, your CT of your heads, your neck, your chest, and then you do your excisional biopsy, not your incisional biopsy, and then you do your neck dissection if warranted. And in this case, if you have an enlarged cervical lymph node that shows a squamous cell on your FNA, well, that's a positive node. So these patients are going to get neck dissections, okay, on that side. If it comes back papillary, it's going to push you into the thyroid realm. So you're going to get your ultrasound of the neck. You may get a thyroid scan, which may or may not help you. Check your calcitonin levels, thinking about medullary thyroid cancer. You'll get a TSH, and then you'll obviously shift gears depending on whether you have a thyroid primary, and you'll follow that route. Again, if it's going to come back follicular neoplasm, you're going to move into the lobectomy, completion thyroidectomy, neck dissection for positive lymph node. Melanomas are going to get your modified radical neck dissection. And although I don't go through it here, I think it's really important to go review the modified radical neck dissection. There are 4 different types, and you need to decide which components you're going to do and not do, whether you're going to spare the SCM, you're going to spare the 11th nerve, and you're going to have to make that decision. Almost always you're going to spare the nerve at this point, and the majority of the time in a modified radical neck, it's only when the nerve is involved that you're going to resect. If your FNA leads you to lymphoma, you're going to complete it with an excisional biopsy. This is most of the time they want the whole lymph node for a lymphoma. And you're going to stage them. You're going to do a bone marrow, you're going to do a staging CT, and these patients are going to be treated with chemo and radiation to the neck. If it shows an adenocarcinoma, you're going to do the CT of the chest, the abdomen, the pelvis. You're going to think about breast cancer. You're going to think about colon cancer, gastric cancer, and you're going to work that up accordingly. Obviously, if that's what you identify, you have stage 4 disease. These patients are going to get a primary resection of whatever you identify as their primary cancer, followed by systemic chemotherapy. Briefly, we'll talk about congenital neck masses, branchial cleft cysts that are going to come up in kids. I list here the differences between the first, second, and third cleft, and there's a 4th cleft as well that's rare. But the treatment for all the cleft cysts, number 1, identifying the right one and resecting it. And you're going to have to localize it based on where it is in relation to the sternocleidomastoid and where it terminates, because you need to get the entire tract, like the hypoglossal duct cyst, for complete surgical excision. A cystic hygroma may come up. You may see a picture of this, which is somewhat impressive. They usually present as these giant lateral neck masses in children. This is an abnormality in lymphatic channels. They usually present at birth, and 80 to 90% are detected by age 2. They're painless, very soft, either single or multiloculated, and the treatment is complete surgical excision. And again, although a few regress, you should postpone the surgery until they're 3 or 4 years of age, as we mentioned before, because some may regress and not need treatment. And lastly, the thyroglossal duct cyst. Again, it's a midline structure. It elevates with swallowing because it's attached to the foramen cecum. It could present anywhere from the foramen cecum down through to the thyroid gland. The treatment is a complete excision of the cyst with its entire course through the hyoid bone to the base of the foramen cecum, and this is called the cyst trunk operation.